mentioned Piece 3, and I just want to highlight one of the points you made there. They were very careful in that study with enzalutamide and radium-223 to put all those patients on bone health. And that was a point that you had made earlier, how important that was. And in prior studies, that was not mandated. And I think that did help in terms of the data.
I think in the ERA-223 study, which was the one you're referring to, that there were a higher number of skeletal-related events, and kudos to the researchers for fine-tuning that on subsequent studies. But to continue Casey's point, in patients that progress to a hormone refractory disease, being able to offer them quality of life by incorporating radiopharmaceuticals. So we know from the Piece 3 study that if you combined radium-223 and enza, these patients had a longer period of time before you needed something like docetaxel. And we know that it's been associated with better quality of life, better patient-reported health quality of life than just jumping into chemotherapy. We also know that you are able to use lutetium or Pluvicto in patients that have had radium-223. You're able to use docetaxel at a later line as well. And in some of the studies, as long as there was, I think, around a 15-month gap between the last time you had radium-223, you could offer them other radiopharmaceuticals.
So some of these treatment intensification options in metastatic castrate-resistant disease do pose a little bit of a dilemma, because so many of our patients now are so heavily pretreated in the castrate-sensitive space. So how do you approach that? You know, we want to give the best that we can do. You know, we know in Piece 3 that if you combine enzalutamide with radium, that the overall survival advantage was roughly 7 months difference between the groups, which is pretty significant for metastatic castrate-resistant disease. But many of these patients have already been exposed to enzalutamide or abiraterone or darolutamide now in the castrate-sensitive space. How do you deal with that dilemma now?
Yeah, I mean, there are options again, aren't they? So because a lot of these patients would have had docetaxel. Now, a couple of options. So if it's been 2 years after the previous docetaxel, there is an opportunity to re-challenge them. Or we can go for cabazitaxel as a first-line therapy in CRPC, and that's been shown. It doesn't have to wait for docetaxel failure. So those are options. And the other options now is the recent study with Pluvicto that came out that said instead of switching to one ARPI, you can try Pluvicto. Now, that study only looked at disease-free, progression-free survival, not the OS data. So it picks a little bit more counseling to the patient that we don't have the data. So I think, and the other thing is, as these patients have multiple lines of treatment, we have to start thinking of neuroendocrine differentiation in these patients. And because of that, as we combine chemotherapy, we have to probably start thinking of adding carboplatin or some form of the platin agents proactively to help with the neuroendocrine differentiation as well. So, and then hopefully we'll have some somatic data, and if they have any of the HRR mutation or thereof, then we can start thinking of PARP inhibitors.
I think it's an important point. The CARD study basically showed that if somebody progresses on docetaxel and an ARPI, like you were saying, the response rate to another ARPI is not good, and so that's kind of where we use the cabazitaxel. But radiopharmaceuticals do play a big role, and I think that's kind of where the biologic nature of the disease, the molecular markers become a bigger selling point in terms of treatment selection and clinical trials as well, if those are available.
So reference was made just a few seconds ago about lutetium, and we have the PSMAfore data now for being able to use that prior to chemotherapy in patients that have metastatic castrate-resistant disease who have been treated with a prior androgen pathway inhibitor. They could have been treated in the castrate-sensitive space even, or in the castrate-resistant space. So how is this going to change our treatment decisions now? And of course, the control arm in that trial was switching to another ARPI, which we know is not I wouldn't say that it's placebo, but it's probably pretty close to that.
Yes.
But still, that the RPFS was significant. So how does that change what we do now for these patients?
As medical oncologists, we always worry about radiation effects in the bone marrow. And so, you know, lutetium being a beta radiator, we know that you have hematologic toxicity. In the VISION trial, it didn't seem to have as much of an effect as I think most people that use it in daily practice see. So for us, you know, when I have this conversation with my patients, I always want them to know that we need to have something in our back pocket. later use of cabazitaxel and carboplatin, like you were alluding to, becomes very difficult in somebody who's had a bone marrow that's been burnt with these medicines. However, if somebody's progressing rapidly, has high volume disease where you don't think that they will have the luxury of having several other lines, then you really have to give this your best shot up front.
I want to also talk briefly about the PARP inhibitors, because those have really entered into this space significantly. And we know that the importance of doing testing, obviously, both germline and somatic testing based on guidelines, liquid biopsies as well. As we burn through therapies and we may not have tissue readily available, we can do circulating tumor DNA. So we have all these assays available now. But who are the real super responders? Who don't we ever want to miss? Who don't we ever want to miss? A patient with a biomarker that's got an abnormality for a PARP inhibitor, because we know that there's certain ones that really respond better than others.
Yeah, you know, patients with BRCA1, BRCA2 mutations are one of the key drivers that we look for. Now, some of the other DNA HRR genes and the DNA damage repair genes, you know, they say they don't respond, but a lot of these studies are underpowered. So we don't know. And there's also data suggesting that these medications can work in patients who do not have HRR gene mutations as well. So if we get to that stage, I think it's certainly worth giving a try. And of course, these drugs are toxic as well. You know, for a oral drug, these have profound side effects, and we need to be monitored. And you know, the discussion is, do you start with a low dose and escalate, or you go to standard dose and de-escalate? So those are the kind of decisions we need to make.
Yeah, I want to let Chris chime in here, because you're going to do prostatectomies on men that you know are BRCA positive up front. How does it change your treatment plan?
Yeah, I think you know, I think for someone like that, I'm more inclined to want to do a lymph node dissection, extended lymph node dissection. I mean, I think you're certainly counseling those men on the likelihood of needing multimodal treatment potentially. So you know, I think you see more and more of this, but certainly from a surgical standpoint, I think those are the things you're thinking about. You know, nerve sparing. I think again, I think I have the same discussion regardless of a genetic mutation that I would have. But I think primarily the big difference would be lymph node dissection, and then just counseling as far as, you know, the road ahead potentially. Because we know those patients are certainly at much higher risk for recurrence and metastasis.
I just wanted to chime in with regard to systemic therapy in these later lines. I think being a little more creative about combinations, synergistic combinations, especially with PARP inhibitors. We know that PARP inhibitors work in DNA repair. So patients that have these mutations and you combine them with radium-223, for example, PARP inhibitors lock the cancer cells in G2 and the M phase, which is actually where the cells are most susceptible to radiation damage. And so that synergy is just a match made in heaven for the patients. And to Casey's point, there are still things we don't understand about how this works, because when you follow ctDNA in these patients, ctDNA improved more in patients that did not have HRR mutations, which was completely contrary to what you would expect. So there are still pathways to be discovered and exploited in this space.
All right. Well, I'd like to wrap things up and maybe get some final words in on the topic. And we've covered a lot of spaces here. We didn't really do much in the biochemical recurrent area, but we covered the metastatic castrate-sensitive, metastatic castrate-resistant space. And as you're thinking about the topics that we covered today, is there anything that really stood out to you as being an important highlight that you would say, this is a real point that I wouldn't want anybody to miss?
Yeah, I think one of the things is the decision making in castration-sensitive space between doublet and triplet therapy. The argument is, if you can give the triplet therapy, that may be the way to go, and especially because it's only 6 cycles, and there are a variety of other options available down the road. And I think, and as long as the patient can't tolerate it, I tend to sway towards triplet therapy. Nick.
Rob, parting words?
I would say, you know, prostate cancer has been in the backseat for so long. We owe it to our patients to keep up with the data. This is becoming a rapidly changing field. In order to offer your patients the best, most current treatment approaches, you need to keep up with the data.
Okay.
Yeah, couldn't agree more. I think somebody mentioned earlier that there's a significant amount of patients out there that are still undertreated when it comes to this space. And so staying up to date, making sure that these patients are getting everything that we have available these days. And then, like you said, more and more men are living longer and dying with their prostate cancer and not from of it because of all these advancements.
And I think one other point I'd like to make is to really try and understand the value of patients. It's not always about quantity, it may be about quality. And while there are significant improvements, we are not curing these patients. And the fact they're all living longer means their quality of life may also be compromised for longer. So these are discussions to be had. And there is the issue of intermittent therapies being revisited now, Yenza holidays and apalutamide maybe that will come to fray where because these patients will live longer, it's okay to take them off for a while.